Hi, I'm Dr. Brian Kaufman, a retired family doctor, chief medical officer, executive vice president of the nonprofit CLL Society, and a CLL patient myself. Dr. Niemann, do you want to introduce yourself, please?
Thank you so much for this invitation, Brian. I'm Carsten Niemann. I'm a medical doctor and hematologist and associate professor at Copenhagen University Hospital, Rigshospitalet in Denmark. I'm focusing on CLL research, and I'm also chair of the Nordic CLL study group.
Dr. Niemann, the big issue for a lot of CLL patients has been their immunocompromised state and how they handle COVID. And you just published an important paper that may shift that and present new information. And certainly what we're learning is that this is a changing area of concern for patients. Can you share a little bit about this research that you just published?
Yeah, so first, immune dysfunction in CLL is a major interest of my research group. And I believe strongly that patients with CLL suffers, and we have also and others have demonstrated that, suffer from impaired immune function prior to any CLL treatment, even prior to diagnosis of CLL, but also during treatment. And actually, we have some data indicating that upon treatment, if patients are in a good deep remission, they may actually improve significantly their immune function. In terms of COVID, all during the COVID pandemic, unfortunately, we have seen that patients with CLL suffer significantly from severe causes of disease, and they need specific attention. What is very good to see now is during the Omicron era in Denmark, meaning from December 2021 onwards, patients with CLL have a better outcome. First, we published a preprint of this paper demonstrating that patients with CLL still had more than a 20% risk of dying from COVID. But what has been very reassuring during the last months is that we have worked further on this study, and we have demonstrated that patients with CLL who do not have close contact to the hospital, and that's actually the majority of patients, they have a much better outcome. Actually, only around 1 to 2% of these patients contracting the Omicron variant of COVID died from the disease. So that's really promising. And to me, it demonstrates that if you're due to the COVID disease or due to the CLL disease, need to see your treating physician at the hospital often, or need to be admitted to the hospital, you still have a high risk, approximately around 20% of dying from the COVID infection. But this is a minority of the patients with CLL who contracted COVID, actually around 10% only of these patients. And they are characterized by having significant comorbidity and being elderly and receiving treatment for their CLL or receiving hospital care for their COVID infection. The rest of the patients with CLL had a much better outcome upon contracting COVID than they did in the prior parts of the pandemic. And this is really reassuring to me.
So am I understanding you're saying that that 20+% mortality rate was only in the 10% that were near a hospital because of needing ongoing care in most cases, or comorbidities, or actually having to be hospitalized to their COVID or CLL. But then in the other 90%, the mortality rate was considerably lower. Is that a correct understanding?
That's correct. And it was considerably lower, as low as 1%.
Wow. So do you think this is because of the nature of Omicron, or or something, or we're treating it better, or something about the CLL patients themselves? Do you have any speculation or any research to enlighten that?
So in Denmark, all patients with CLL will have received 3 and actually now 4 vaccinations for COVID. And the combinations of being fully vaccinated and the Omicron variant being much less aggressive in terms of lower respiratory tract infections, I believe strongly this combination is what is protecting our patients now. So even though we know, and we and other groups have published, that COVID vaccination in CLL does not give the same degree of protection, especially not the same serological, meaning like the antibodies produced by the vaccination is not the same as in the background population. It seems that the booster vaccinations, the third and the fourth vaccination, actually gives some protection, and especially also the cellular protection, indicating that the cell part, the part of the immune system built by cells, will
You're
actually
talking about the
protect.
T cells here, is that right?
Yeah, so that's a T cell function. So even though we know that T cells do not work perfectly well in CLL, it seems that the repeated booster vaccination can give protection. And that has been demonstrated in a few papers, one Danish paper and then another international paper, that this can actually be demonstrated in CLL cells, that you can boost these T cells and they can give some protection. And then the Omicron virus has a lower risk of giving you a lower respiratory tract infection. It seems more often to give an upper respiratory tract infection like a common cold. And it seems this combination of full vaccinated and booster vaccinated patients with CLL and the Omicron actually give a much milder disease course for the vast majority of patients with CLL.
Well, this is very exciting, though. If anything we've learned from COVID, it's learned to be humble and that making predictions are not good. But it sounds like this is very good news for the CLL community. What advice are you giving your patients in lieu of these findings?
So before the Omicron variant, the advice would be to be very careful, still to keep precautions in terms of contact with other people. And at any time, if you test positive for COVID, immediately seek contact to your department or your hematologist to receive passive immunization and hospital care if needed. Now that has switched, still try to avoid COVID, but actually the Omicron variant seems not to be a major problem to most, like more than 90% of patients with CLL. And I don't even recommend at a national basis anymore, in discussions with colleagues, that all patients with CLL receive passive immunization with some of these monoclonal antibodies that you can receive. I only recommend that for patients who would be on active treatment or who would, for other reasons, have close hospital contacts. And that's based on this recent paper from our group.
Well, this is very exciting and really kind of a shift in the way to think about how to handle this. And I think it's positive news. And though, like I think both of us would agree, we have to keep our eyes open, and there's no guarantee the next variant won't change that whole dynamic.
I couldn't agree more. I mean, this could totally change in half a year if we see a new variant. And we need to keep that, and that's a major focus of our research, that we need real-time data. Because if we don't have real-time, high-quality data, we cannot detail from month to month how this pandemic and the risks for our patients, whether patients with CLL and also more broadly patients with hematological malignancies, change over time or not.
Any final thoughts you want to share with the patient community about your research in CLL and COVID in particular, or even CLL, COVID, and general infections in general, whatever you want? The floor is yours.
So two things. First, I've been working beforehand in the US and now in Denmark, actually also in Brazil. So I can't emphasize enough how important it is that we use the joint health data for good quality academic research, that we use what I would consider epidemiological data or real world data to inform data-driven healthcare. It's so important that our politicians and our data owners, being the different hospital systems, understand that we need to contribute these data and use them to improve patient care. And secondly, based on the Vision HOVE 141 trial that was just published a day ago in Lancet Oncology, we have demonstrated that even for patients with relapsed refractory CLL, a combination treatment with a BTK inhibitor and a BCL2 inhibitor, combined with measuring the minimal residual disease that the patients have, can actually give us the same story that we saw before for patients with a sister disease, CML, chronic myelogenous leukemia, that we can stop treatment for patients and restart treatment prior to any clinical relapse. So we can follow patients now with CLL, even relapse refractory patients with more aggressive disease. We can give them time-limited combination treatment. We can measure the minimal residual disease, and we can stop treatment and reinitiate it again. So this is really one important step further towards personalized treatment for patients with CLL.
Dr. Niemann, I'm very excited about you taking a look at the immunological basis and understanding that CLL comes in many different flavors and that there are people that are high risk and low risk, and you've got to really assess that for yourself. One size does not fit all. Second, to be moving towards limited duration therapy and using MRD. That's a whole other topic that I'm going to try to set up another interview to discuss with you. And third, just the whole idea of using real world data, I think, is critical, not only in terms of determining the what treatments are the best, but also in terms of how do we get medications developed into market? How do we monitor their safety? I think that it's very important that real world data be part of those decisions about how we treat CLL. I can't thank you enough for your time and for the research you're doing for the CLL community. Thanks so much.
Thank you so much, Brian. A pleasure meeting you here and discussing this.
Thanks.